Today we discuss endometrial polyps, how to read the semen analysis, and we check the mailbag. I'm Dr. Mark Amols, and this is Taco Bout Fertility Tuesday. So, what is an endometrial polyp? I think the first thing to understand is, when do you find endometrial polyps and why would you find endometrial polyps? When you first see your fertility doctor during the general workup, it's not uncommon for them to check for polyps. The way we do this is with what's called a sonohystogram, or sometimes called a saline infusion sonogram. And we look inside the uterus for things that could be wrong, such as scar tissue, abnormal shape of the uterus, and uterine polyps, also called endometrial polyps since they come from the endometrial glands. And when you do IVF, this is always going to be tested. It's extremely important. Matter of fact, I have patients all the time who will ask me if they cannot do the sonohystogram, and I explained to him that there's no point for even doing IVF if you're not going to do the sonohystogram. It's probably one of the most important tests. If you think about it, that's not very surprising. If you were going through all this work to make these beautiful embryos, why would you not look in the place you're going to implant them? That should be the most important place to make sure looks good. It's not like you're going to try to make friends with Brad Pitt and bring him home to your dirty home. No, you're going to get someone to clean up your house. You're going to make it look good. You don't want any endometrial polyps showing up around there. He's not going to be impressed. Well, the same thing when it comes to treatment. You need to make sure that your house looks good. Now, the most common cause of abnormal bleeding is from polyps. And as a matter of fact, that's how many people find them, is they're having irregular bleeding and they see their doctor. Now, again, in fertility, we take it a step further because it can cause infertility. It can even cause miscarriages. So when women have problems with miscarriages or when they are not getting pregnant, we like to look for these. Two situations I highly recommend always getting a sonohystogram are women who have irregular cycles, because the chances of finding a polyp are very high. The second situation would be anyone going through IVF. Now, again, what is a polyp? Well, the medical definition would be a hyperplastic overgrowth of the endometrial glands, and it projects from the endometrium. That is the lining of the uterus where you have implantation. I think it's easier to think of it like a skin tag. If you think of a skin tag that's like on someone's neck, it's a piece of tissue hanging off. It looks identical, except it's inside of the uterus. And the importance of these polyps is that it can have abnormal blood flow to them, and it can create inflammation into the uterus. But we'll go into that in a little bit more. Now, when you see them, you don't actually have to remove them if you're not having any issues. So if you were, let's say, not trying to get pregnant and incidentally someone found a polyp and you were young, you really don't have to remove it. But in fertility, we always remove it. Matter of fact, that is one of the factors that would lead someone to have it removed, is trying for fertility or having infertility. I get asked a lot, what causes them to grow? And the way I like to explain it is almost irritation, that the tissue inside the uterus is rubbing together, and that can create these skin tags similar to the neck. Now, technically, it is called hyperplasia. It's when the cells in the endometrium are dividing multiple times, creating this tissue. It can be due to things like overexpression of certain hormones like aromatase. And it also can be due to gene mutations. As a matter of fact, that's one of the reasons why when you're older and you have polyps, you always want to have them removed because they can be cancerous. Now, in young women who are undergoing fertility treatment, it would be almost 0% chance of being cancerous. However, anytime you remove them, you should always send them to pathology. Now, the risk factors for having polyps are kind of like I mentioned earlier. The highest risk factors are going to be people who have irregular cycles or anyone going through IVF. We're going to test for it. But the risk factors are still most likely going to be obesity or people with PCOS. Now, why both of those groups? Well, when you are overweight, whether you're a man or a female, you have higher levels of aromatase. And this enzyme is what converts testosterone, the estrogen. So when you're overweight, you make more estrogen, which can then lead to a higher rate of having uterine polyps. Now, if you're a guy, obviously you don't get uterine polyps because you don't have a uterus. But that's how men get man boobs. It's from being overweight, making more estrogen, and you get those lovely things on a guy. Now, PCOS causes it in two ways. Yes, it can be from elevated estrogen levels, but it also can be due to elevated insulin levels. Now, how do you find these things? Well, one of the ways we do it in reproductive medicine is we do these sonohistograms, saline infusion sonohistograms. Now, these are great tests for it because you're filling the uterus up with fluid, and then you're able to see inside it. You can see a polyp. You can see the rest of the surroundings. So you can see the uterus. You can see the ovary. So that's the benefit of doing it that way. Technically, you can see a polyp on a regular ultrasound, but it can sometimes be false. Sometimes you may miss things. So I always recommend either a saline infusion sonohistogram or doing a hysteroscopy. Now, with a hysteroscopy, you're able to look at the actual tissue. You can see the polyp. You can see how big it is. Where is it at? Is it at the fundus? Is that near the what we call ostia, which are the opening of the tubes? Is it lower in the cervix? Hysteroscopy, without question in my mind, is the gold standard. However, if you are confident in sonohistograms, also called saline infusion sonograms, then I think those could be just as good and don't think you have to do one over the other. But if it's difficult to see the SHG sonohistogram, then I'd recommend doing the hysteroscopy. So how common are these? Are these rare, like finding a taco shop in my old state of Minnesota? Or are these as common as seeing the filibertos in every corner of Arizona? The answer is we really don't know because we don't test every woman because some women don't have symptoms. But when it comes to infertility patients, we find that about 6 to 8% of women have it. That's a pretty high percentage. Essentially, every 13 patients is going to have a uterine polyp. So what's the big deal? It's a skin tag. I mean, some people have them. Does it hurt anything? It does. Matter of fact, there are two ways that polyps can affect things. The first way is the blood supply to the polyp is very poor. And if a pregnancy lands on that polyp, it could lead to a miscarriage. And clearly, anytime you're going through fertility, any miscarriage, regardless how easy it was to get pregnant, is going to be very, very heartbreaking because it took a long time to get there. Especially if you go through IVF, it could even be that much more disheartening. But the other thing that can happen is that a uterine polyp can act like an IUD. IUD stands for intrauterine device. These are pieces of plastic and metal placed in women's uteruses to create inflammation that then prevents implantation. Well, a polyp is very inflamed, and that environment is so toxic to implantation that the inflammation leads to infertility. I've seen many women who can't get pregnant. We do a polypectomy, pregnant the next month, no issues. So you can see why these are very important anytime you have infertility, and why, especially if you're paying money or putting your hopes into these fertility treatments, you need to evaluate the uterus. It amazes me all the time when I have patients worried about doing a test that I know is not cheap, but it's not exorbitant, to save a few dollars when they've spent thousands of dollars on things like IVF and IUIs. It is an extremely important test, and I would never recommend anyone doing an IVF transfer without having a saline infusion sonogram or a hysteroscopy before the transfer. The question is, how soon before the transfer? I don't think there's an actual given rule. I know some places will be up to a year. I've seen studies that show that within 6 months, polyps can return. So I generally use that as a rule. But obviously, you have to look at the situation. If you have someone who has a history of polyps and they return faster than 6 months, then you need to do that testing within that time frame before your transfer. For my clinic, 6 months is the rule. If you go past 6 months, we recommend doing the saline infusion sonogram. Today, we are extremely lucky. We have a special guest today. My 6-year-old son, also known as Dr. Augie, who is going to introduce this next subject matter, the semen analysis.
My name is August. Have you heard of this thing called sperm? It looks like a snake, but it's not. It's not big like a snake, but it's really tiny. You can only see it in a scope. But if they go inside an egg, it will create a girl or boy. So yeah. And there's another one called the egg, which is one sperm could get in the egg. But as you all know that it takes 100 days for the baby to get out of the stomach. It's really crazy, right? I hope you enjoyed that. So yeah, bye.
I've touched before on the semen analysis and how it's important, but I want to go over tonight the details of the semen analysis. And as a patient who maybe hasn't seen a fertility doctor who had a semen analysis done, I want to give you the skills to be able to read that, because I find a lot of OBGYNs don't know how to read it, and that's appropriate. And they didn't go through a fellowship like I did. They didn't do the extra training, so I don't expect them to read the details. In the end, what most people do is they look at the count, they look at the big numbers, but they don't look at the detail. And the detail can matter. And that's what we're going to talk about next. Now, when you look at a semen analysis, one of the first things we look at is the volume. Now, with that, there are other factors called liquefaction, viscosity, pH, appearance, other. It's going to be a little complicated to go over all those details, but let's talk about the main ones. The first one is volume. Why does volume matter? Well, too much volume can cause issues with diluting the concentration of the sperm. We'll get into that a little bit when we get into the main part of the semen analysis. Right now, we're talking about the semen characteristics. But if the volume's too low, it can actually create a lot of problems. Generally, if you see the volume less than 1 milliliter, and the rest of the sample is normal, you may have problems getting pregnant. It doesn't mean if you have low volume, you need to see a fertility doctor. But if you're already having problems and then you see low volume, there can be issues. And the reason it causes this is because the vaginal canal actually gets larger near the bottom, and the sperm can kind of get lost in those vaginal folds. And if there is less volume, then the sperm can't liquefy as much and cover the cervix. And the cervix is the entrance to the womb. Now, the next factor we look at are things like pH. pH represents if the prostatic glands and the seminal-vesical glands are producing volume. Almost all the sperm can fit in the tip of a pen. Everything you see is seminal-vesical fluid or prostatic fluid. Now, prostatic fluid is acidic. Seminal-vesical fluid is basic. Together, they combine and make a pH a little above 7.2, but around there. If it's higher, meaning more basic, then there would be concern that maybe there is stricture at the prostate or a blockage. If the numbers are lower and the sperm is more acidic, then the concern could be is that there could be blockages at the seminal vesicle, which can happen with chlamydia infections and things like that. Now, the main thing you want to be looking at pH is it really far off? So is it in the 9 range or in the 6 range? If it's in one of those, there's a problem and they need to see a urologist. The other thing we look at is appearance. Things like red would represent blood, and that would be very concerning. Next, we're going to discuss the semen analysis portion. We're going to start with the count. The count is broken into several portions. There's what's called the total ejaculate, which is the absolute amount of sperm that you make. This is usually going to be around 40 million or greater. There's the concentration, which is how many sperm you make per milliliter. This needs to be around 20 million or greater. And then the last part of the count is the total motile count. That's saying how much sperm you have that's actually moving in the ejaculate, and that should be 20 million sperm or greater. Now, why do these matter? Well, a general rule is if you have 20 million sperm or above that are moving, so we're talking about the total motile ejaculate, you can get pregnant naturally as long as there are no other factors. If the count is between 10 and 20 million, you're probably going to need intrauterine inseminations, IUIs. But if it's less than 10 million, you're going to need IVF. Now, could you have a good total motile count and still not be able to get pregnant naturally? The answer is yes. Matter of fact, when you are looking at the total count, that's the absolute amount of sperm you make. But with intercourse, all that sperm isn't getting in there. If you're a female, you know this. Most of it's going to come back out. Only the sperm touching the cervix is ever going to get inside the uterus. Matter of fact, of the millions and millions of sperm that men make, only about 100,000, 200,000 sperm actually get into the uterus. Now, what if the concentration is low? So again, you have plenty of sperm there. If you take that whole amount, there is plenty. But if the concentration is low, that is the sperm touching the cervix. And if that is low, then you will have problems getting pregnant and you will still need IUIs. Now, this brings me to a point that I find actually very funny because whenever guys have a lot of sperm, they're quite proud of it because, they definitely did it on their own that way. But what I find really funny, and when I tell them this, you can definitely see their ego kind of drop, is I remind them they don't make a lot of sperm because they're so good at doing it. They make a lot of sperm because they're so bad at making sperm. It takes them millions and millions of sperm to make a few good ones. The next thing we look at in the semen analysis is the motility. And there are many ways to look at motility. You can look at what's called the in-modal rate, the progressive rate, the non-progressive rate. We're going to keep this a little bit simple. We're going to talk about first motility, and then we're going to talk about progressive motility. Now, the word motility sounds like it's a percentage. If you hear, oh, my sperm is 30% motility, that doesn't mean that your sperm moves at 30% the rate. What that means is that 70% of your sperm is dead. And the way this can cause a problem is if there's a lot of dead sperm, it's hard for the good sperm to get to where they need to go. Imagine you're in a burning building and there's one door and the building's on fire and 100 people in that room, and 70% of the people said, we're not going to move. It's a lot harder for you to get out of that door. Well, just the same way, a lot of dead sperm can prevent other sperm from getting in to the uterus. Now, progressive motility is different though. Progressive motility is the ability of the sperm to move forward. And this can sometimes be called grade or progressive motility. And it's usually graded as a 1, 2, 3, or 4. Now, a 4 is the best you can be. That is literally the Michael Phelps of sperm. You're going to win an Olympic gold with that one. Now, if you're a 3, you're not Michael Phelps, but you're like a high school, college swimmer. Really good, much better than most of us. If you're a 2, you're like me. You're not going to drown, but you're probably only going to do a couple laps and you're going to be pretty tired. If you're 1, you're running around in circles or drowning. The point is you want to be at least a 3 or above. If you're less than that, you may not be able to get pregnant even naturally. Matter of fact, a lot of times men will go in for IUIs and they'll drop off their sample and they'll wash it and then there's almost no sperm left. And the reason is because when they put it through that gradient, the sperm is so poor in motility, most of it gets lost and their count falls very, very low. In this situation, the only option is then moving on to IVF if you can't filter the sperm without losing most of the sperm. Now, the next thing we're going to talk about is morphology. Morphology is the way the sperm appears. Essentially, you want your sperm to look like Brad Pitt. You want perfect shape, perfect size. And the reason for that is because the outside of the sperm has a thing called an acrosome on it. And that undergoes a chemical reaction that allows the sperm to get into the egg. It's not a mechanical action as much as we think. They're not knocking on the door saying, I'm here. But instead, it's this chemical reaction. So if the head of the sperm is abnormal, or if there's 2 heads or a couple tails, either the sperm can't swim there, or the sperm can't get in the egg. Now, this scares a lot of people for a couple of reasons. First, a lot of fertility doctors will tell you that if you have abnormal shaped sperm, you can't get pregnant. And that's just not true. And the reason it's not true is because, yes, they're abnormal sperm, but we just got done saying earlier that the reason guys make a lot of sperm is not because they do it good, but because they do it so poor. We expect sperm to be bad. I tell people all the time, Superman himself wouldn't have above 15% perfect sperm. Why would we expect us average guys to have better than Superman? The problem is that when you do IVF, we don't have a way to filter the sperm. So that 3% morphology, meaning only 3% of your sperm looks as good as Brad Pitt. The problem here is that I can't filter it for IVF, so I have to then take that sperm and inject it into the egg. Whereas when you do IUIs or you're having intercourse, the reproductive tract of a woman is like the American Ninja Warrior course. It is so hard for that sperm to get through there. By the time it gets to the end, it is the best of the best. It's the LeBron James of sperm. It's only going to win a championship. But in IVF, I have to inject the sperm in. Now, I'm not injecting in because there's something wrong with the sperm. I'm injecting in because I can't filter it as well. But this can be a little scary because if a doctor tells you they have to inject your sperm in the egg, it's very easy to think, well, then I'm not getting pregnant without doing IVF. And that's just not true. Now, if that count is zero morphology, it does not mean you have no normal sperm. It just means that they couldn't find any. They only look about 200 sperm. There's probably normal sperm there, but in that situation, it's not unreasonable to say, listen, it's been 5 years. We haven't got pregnant. My morphology is zero. Maybe we should go straight to IVF. And I don't think anyone can argue with that. But no one can say to you, there's no way you can get pregnant naturally. That's just not true unless there truly was 100% of your sperm abnormal. The last part of the semen analysis we're going to talk about is inflammation, which is the round cells that are sometimes reported on a semen analysis. Now, when that is high, the concern is there might be an infection. Usually once that's above 1 million, that's when we would be concerned. Now, not every clinic is going to separate the round cells from white blood cells, and we'll just report it as round cells. Now, when you're trying on your own or you're doing the IUI, some round cells are not going to affect anything because, again, we have that reproductive tract that's going to filter the sperm. But when you do things like IVF, we can't take that chance. We can't just put sperm on top of the egg, because if there's round cells there and there's potentially infection, that bacteria will now be on the egg. And so whenever we encounter round cells in IVF, especially on the day of a retrieval, we always inject the sperm into the egg to prevent possible transmission of that infectious material around the egg. Now, does that mean you absolutely have infection? No. But who wants to take that chance at that point? Now, if you're doing a semen analysis and see this, and especially if the semen analysis has a low result, it is recommended to take a course of antibiotics and then repeat the semen analysis. I think the most important thing in summary is that semen analyses are not easy to read. Even the information I gave you is just the tip of the iceberg. I would tell you, if you've been trying for a year and you've had a semen analysis, make sure a fertility doctor reads it because it makes a difference. I've seen many patients who I would have called a semen analysis normal, but then I hear the history and I realize it can't be normal. For example, I've seen guys who come back borderline. Well, why wouldn't you think that's normal? It falls into normal, it's borderline. But then I hear they've been trying for 3 years. In my mind, I know that guy probably had his best day ever. And in reality, that sperm count is probably much lower. And when I repeat it, I'm right. And so that's why that history has to go with the semen analysis. There's nothing wrong doing the semen analysis in the beginning and having an OB look at it. But if you have a complicated history, or it's been more than a year, definitely make sure a reproductive doctor looks at. Sometimes some clinics where they do this semen analysis will call you and give you the results, such as a fertility place. I'd recommend using those over just a standalone lab that doesn't give you the results. This week's question asked, what supplements do I recommend for those trying to conceive, IVF, or frozen embryo transfers? And do I recommend a specific brand for prenatals? You know, this is a very tough subject because when it comes to supplements, there are some that are absolute, such as prenatal vitamins. Every single person who's trying to get pregnant should be on prenatal vitamins. The purpose of this is the folic acid. What that does is help prevent spinal tubal defects that can develop. So everyone needs to take that. Now, some women with things like MTHFR, they would benefit from methylated folate. I don't recommend any brand. I just recommend those two things. Now, almost all prenatal vitamins have folic acid in it. Basically, I tell people if you have a normal diet and you're getting some variability in your diet, you can use the cheapest prenatal you found. If your diet is very poor and you don't have many omega-3s in your diet, then you might want to add things like fish oil, or you can buy prenatals that have it in it. Now, when we're talking about other supplements, there are some things that are also good to have. One of them is vitamin D. Vitamin D in almost everybody is low. And that's mainly because we don't sit out in the sun and get sunburned. And so most of us are indoors when there's a lot of sun and we don't get vitamin D. So it's a very good vitamin. It definitely affects your fertility and improves outcomes in the pregnancy. So it's important to take that one. When it comes to people with PCOS, I highly recommend a vitamin called inositol. I happen to like a company called Theralogics, but it's not the only company that makes it. It's extremely beneficial for people with PCOS. It helps with inflammation and insulin levels. The last vitamin I recommend is going to be CoQ10 and DHEA. Now, CoQ10 can really be taken by anyone. That is a vitamin that's going to help repair damages that occur in the body from free radical damage and environmental oxidative stress damage. CoQ10, when used in people with diminished ovarian reserve or poor embryo quality, can have some benefit. Now, the thing you have to remember is when you're starting a prenatal vitamin, vitamin D, folic acid, as soon as you start those, they are working. But when it comes to CoQ10, there is some benefits right away, but the greatest benefit would be to be taking that for at least 3 months prior to your retrieval, because it would take that long for the eggs to absorb it, because the eggs that are retrieved were selected 3 months ago. And so it takes that time for them to develop. DHEA is another vitamin that is a weak testosterone that has been found to help with women with diminished ovarian reserve. Now, again, this is very similar to CoQ10. It needs to be taken for 3 months before your retrieval. Now, I don't use DHEA unless people have diminished ovarian reserve. I have seen some clinics that give it to everyone. The reason I don't is DHEA can lead to things like oily skin, some unwanted hairs, which aren't that big of a deal. But if it's not going to benefit you much, and the literature is a little scanty on this, I don't require for everyone. But if someone has diminished ovarian reserve, and especially have fewer eggs, I do recommend DHEA and CoQ10. My wife as well, she went on those when we went through IVF ourselves. Now, there are these vitamins that are these fertility blends, and I think those are fantastic. There's Fertility Aid, there's Theralogics, tons of brands. And I think those are the best instead of buying all these pills separately. When it comes to sperm, there is a huge benefit. By taking antioxidants and L-arginine and zinc and the CoQ10 that are sometimes in these, it helps improve the stress around sperm and can improve it. Now, it's important to understand that none of these things are going to be huge benefits. No woman's going to take CoQ10 and DHA and all of a sudden have eggs of a 25-year-old. A man who has bad sperm is not going to take these, sperm supplements and all of a sudden his sperm goes from horrible to amazing. But it's kind of like any little amount will help. And that's what they're for. I wouldn't put all your focus onto them, but I definitely think they're worth taking. And if you ever want a specific company, please email us at TBFT, which is the acronym for Taco Bout Fertility Tuesday, at newdirectionfertility.com. Again, that's TBFT at newdirectionfertility.com. And I'm more than happy to give recommendations. Thanks again for listening for another week. As always, please help us get known by rating us and on iTunes, on any source, to get the word out. And please send questions to the email. It helps me with topics and answer some questions that I didn't think people would ask. So it helps me come up with ideas. Until next time, have a great week, and I'll see you next week for Taco Bout Fertility Tuesdays.